I think in general that we're witnessing in these last years a major shift in the management of many hematological malignancies, not only a few. I mean, we're used to having a situation where already for some time in 3 forms of leukemia, the management is largely, as we call it, targeted to a genetic defect. And this has changed dramatically, I would say, the course of disease and the prognosis. And if we take an example of chronic myeloid leukemia, with the tyrosine kinase inhibitors, we are now very rarely transplanting a patient, while in the old days, transplant was the only option. And this, I think, has got bigger and bigger. And we've seen this applied to Philadelphia positive ALL. In the old days, we saw the acute promyelocytic leukemia. Now we're seeing even the most frequent leukemia in our world, in the Western world, which is chronic lymphocytic leukemia, which now can be managed with these inhibitors of the B-cell receptor signal. It's not a genetic defect, but it's not a specific genetic marker, so we're targeting a pathway. But this is targeted treatment, so it's less chemo immunotherapy, and going towards these inhibitors. This for CLL, I would say it's a real revolution. Then we are having the whole era of always more monoclonal antibodies, which are being effective, and examples are in myeloma, in acute leukemias. I mean, again, in ALL, there are a number of monoclonal antibodies which are extremely interesting to consolidate treatment that we attain with chemotherapy. So as I see it, that is a major shift towards years of chemotherapy. Now we're shifting, I would say, quite rapidly and fortunately to an era of much more targeted treatment, biological. There's a return to immunotherapy, which is another very important step forward, monoclonal antibodies or biological management, NK cells. So I think this, going back to your initial question, I think that is a major shift that we're witnessing.